Hello, class, and welcome to Forensic Psychology. My name is Dr. Neil Soggie, and this week we're going to be diving into a little bit of violence assessment and risk of recidivism assessment, which is, I think, a very interesting topic and a very critical area in forensic psychology that really intersects well, I think, with the fields of clinical work in public safety and law. So I want to just kind of start off with a fun little questionnaire. So if you could just kind of grab a little note or something where you can kind of record your answers here. I want to just kind of give you a little questionnaire to kind of simulate a little bit of the basic risk assessment of violence. So it shouldn't take too long. Just need to record, your true and false for each of the following. So if it's true, just give yourself a little check mark or something. First question. In the last 2 years, I have struggled with controlling my anger or temper. So if that's true, just give yourself a check mark. In the last 2 years, I have used drugs or alcohol more than I should have. Next one. I have felt I could hurt someone during moments of intense frustration or stress. Question number 4. Over the last 2 years, I've experienced significant conflict in my close relationships with family, friends, or partners. 5. I've been involved in physical fights or violent confrontations in the last 2 years. In the last 2 years, I have lost a job or had trouble finding stable employment. 7. I have had trouble managing my emotions, such as feeling impulsive or acting without thinking. 8. I have been involved with law enforcement or legal trouble in the last 2 years. 9. Over the last 2 years, I have felt isolated or disconnected from friends or family. 10. I have had easy access to weapons, firearms, or knives in the last 2 years. 11. In the last 2 years, I have experienced periods of extreme anxiety, depression, or other mental health struggles that have affected my behavior. 12. I have felt like I have had little control over important aspects of my life in the last 2 years. 13. I have had friends or acquaintances who encouraged or participated in violent or criminal behavior over the last 2 years. 13. I have felt that my financial situation has put me under a lot of pressure or stress in the last 2 years. 15. I have participated in a support group, therapy, or counseling in the last 2 years to help manage my emotions or stress. 16. I have experienced significant personal failure or rejections in the past 2 years, and it's made me feel angry or upset. 17. In the last 2 years, I have had difficulty controlling urges or impulses when I'm upset. 18. I've relied on alcohol or drugs as a way to cope with stress in the past 2 years. 19. Over the last 2 years, I have felt disconnected from my community or lacking in a sense of belonging. And 20. In the past 2 years, I have had thoughts of hurting myself or others when feeling overwhelmed. Okay. Now, what we're going to do is just kind of count up all of your true responses to any of those questions. Just count them up and get yourself a total. And let's just do a little bit of a cursory, not official, but cursory assessment of yourself. So if you are 0 to 5 of the true responses, we'll say that you are a low risk. If you are 6 to 10 of true responses, we would say you're at a moderate risk. And if you are 11 or more, we would say that you're at the high risk. Now, this is, remember, just a fun little class experiment. But there are cutoff points for this sort of thing. And in actual violence risk assessments, the cutoff points between the low, moderate, and high risk are determined through validated research. And so later on in this lecture, I'm going to talk to you a little bit about some of the tools that we use to incorporate more nuanced variables to predict violent behavior more accurately. But I hope you see there that it is an interesting exercise. Now, in this lecture, what are we going to be looking at? As always, I like to start with a little story. And then we'll dive into our 3 main themes of this week. The first one, it revolves around the identification and analysis of both risk factors and protective factors that influence violent behavior, because peer-reviewed research really does indicate that the most accurate violence assessments consider not only factors that increase risk of violence, but those that might also mitigate or protect against those factors. So there are the risk factors, which are things like your history, your substance use, your mental health issues, environmental stressors. And then there's protective factors like support systems. Then we'll dive into our second theme, which is the violence risk assessment tools and methodology. So we'll look at the different actuarial tools and something called the structured professional judgment, which is kind of a combination of clinical expertise and structured guidance that allows for a fairly nuanced evaluation. And there are some other tools as well that look at historical, clinical, and risk management issues. And then finally, we'll dive into the issues of recidivism and look at the difference in the relationship between violence risk assessment and risk of recidivism or reoffending. And this is particularly relevant when considering decisions about parole or probation or release. And so peer-reviewed literature highlights how the assessment of both general and violent recidivism risk is crucial in determining appropriate interventions and managing public safety. So we'll look at also a little bit of the treatment strategies aimed at reducing the risk of violence and recidivism. Now, as always, I like to start with a little story, and today our story is about John Monahan, who is widely recognized as one of the most influential figures in the field of violence risk assessment within forensic psychology. He has had a lot of contributions that have shaped modern understanding of how we predict violent behavior, particularly within the legal and clinical context. He's someone that was born in 1956 and has had a rich academic journey in research and practice in forensic psychology and in the development of risk assessment. One of his most influential works is the prediction of violence and being able to look at the psychological aspects of violent behavior. In the time between in the 1990s, one of Monahan's most significant contributions was his role in leading what is called the MacArthur Violence Risk Assessment Study, which is one of the largest and most comprehensive studies in violence risk conducted to date. And this study revolutionized the understanding of how risk factors interact and how to statistically predict the likelihood of violence. And the findings really emphasize the importance of dynamic risk factors such as recent life stressors and protective factors, significantly impacting on how risk assessments are performed. Monahan has also authored numerous influential books. One is called The Clinical Prediction of Violent Behavior back in the 1980s. It was really, at the time, considered very landmark. And he also co-authored the book Rethinking Risk Assessment, as you see there, the MacArthur study of mental disorders and violence in the 2000s, which provides a fairly in-depth look into the results of the MacArthur study. And that really kind of cemented his reputation as a pioneer in the field, kind of disseminating that information. And Monahan continues to work on violence risk assessment tools, particularly promoting the use of structured risk assessment tools that combine both clinical judgment and the actuarial data. And that tries to bridge the gap between traditional clinical methods and more statistically driven evidence-based approaches. And so his insights into how things like mental illness and substance use and environmental stressors contribute to violence have shaped many of the modern tools we use, including the Violence Risk Appraisal Guide and what's called the HCR 20, which is something that we'll talk about a little bit later. So I don't want to get ahead of myself too much. He's also won awards for in the APA, the American Psychological Association, and the American Psychiatric Association, and particularly in the field of trying to combine the interdisciplinary work of law and psychology. So really it all ties into decision making regarding violence risk. So John Monahan, the name to keep in mind when we are thinking of risk of violence and violence assessment. Now, let's dive into violence assessment, because at its core, violence assessment involves evaluating the likelihood that an individual will engage in violent behavior, obviously. In forensic psychology, this assessment is critical in various settings, including criminal justice system, as well as in things like psychiatric facilities and community safety initiatives. And the goal is not only to predict violent behavior, but also to develop targeted interventions that can prevent harm. So it's about predicting future violent behavior. It's assessing the probability of an individual committing violent acts in the future based upon our best current and historical data. It's about identifying risk and protective factors, examining the presence of risk factors like history of violence, like mental illness, and protective factors like strong social supports and adherence to treatment. Support of decision making. So it's about, how can we inform decisions related to parole or sentencing or institutional placement and treatment strategies, ensuring that individuals and public safety is all taken into consideration. So violence risk assessment has really evolved significantly over time. It's been driven by advancements in criminology and statistics and psychology. So in the early days, prediction of violent behavior was based upon a person's clinical intuition or their professional experience, with really little empirical evidence to support their accuracy. But over time, things have become more structured, more evidence-based. In the mid 20th century, predictions were largely based upon unstructured clinical judgment. The psychiatrists and psychologists relied upon their experience, which is not invaluable, but methods tended to be inconsistent, and there were some errors that would creep in, and that's something that was found by Monahan. And as psychology grew more empirical and focused more on the research in the 80s and the 90s, there was the development of the actuarial risk assessment tools. And these tools use statistical models based on very large data sets to calculate the likelihood of future violence. And one of the earliest and most influential tools during this time was the Violence Risk Appraisal Guide, or the VRAG. And this is something that remains around today, of course, in its revised version. And actuarial tools significantly improved the predictive accuracy compared to the unstructured clinical judgments that were there previously. So there was a significant improvement. Then in the late 1990s and the 2000s, researchers introduced something known as the structured professional judgment frameworks, which was a combination of the empirical rigor of actuarial tools with the flexibility of clinical expertise. So the structured professional judgments is something like the HCR 20, which allows clinicians to systematically assess risk factors while also considering what is case specific in the details. So using this hybrid approach offers really, I think, a little more holistic way of evaluating violence risk and remains a standard in forensic psychology today. So what does the HCR stand for? Well, the HCR stands for the historical, that's the H, the clinical, that's the C, and the R is risk management, 20. So this is one of those most widely used structured professional judgment tools. And as far as the historical factors go, individuals with past behaviors are considered in terms of things like, their past violent behavior, early maladjustment or problematic behavior in childhood, history of substance use, and history of mental illness or personality disorders. So that's the H. Then the C, the clinical side, would be, are there any active health symptoms like paranoia or hallucinations? Is there problems with impulsivity or lack of behavioral control? And is there a lack of insight into their own mental health risk? And then the R is the domain that really kind of focuses on the future circumstances that could influence risk violence, particularly after release or during community supervision. And these factors often assess how well an individual can manage their risk in the community. So things like lack of structured community support, problems with housing or employment stability, or non-compliance with treatment plans. So the HCR 20 is a tool which means that it's structured. It uses that professional judgment and also the actuarial side, but it isn't strictly actuarial. So it has that nice holistic balance to it. And these are a couple of tools, the Violence Risk Appraisal Guide and the HCR 20 are a couple of tools that really do a good job in helping us to work through violence risk assessment And I think that's important because there are a lot of reasons why we need to be concerned about violence risk assessment. Let's just take, for example, in the criminal justice system. Violence risk assessment is commonly used to inform decisions about parole or sentencing or release. In psychiatric facilities, it's used to determine how appropriate the level of supervision and care is. Patients with higher risk levels may require more intensive interventions or to be placed in a more secure facility. It also has to do with community safety and policing, understanding that how we can identify individuals who may be at risk of violence and are able to implement preventative measures go a long ways to helping to keep the community safe. And there is also the predictive accuracy and preventing of harm that goes into this whole process. So there's a lot that we need to consider, and the value of violence assessment is significantly great because of that. Now, let's go on and take a look at the theories of violence. How do we understand where violence comes from? And there's a lot of different approaches to this. One model to understand violence would be the biopsychosocial model, which really tries to be a comprehensive model that looks at the intersection between the biological, the psychological, and the social factors. When we think in terms of the biological factors, we're looking at things like genetic predisposition, neurotransmitter imbalance. Are there abnormalities in serotonin or dopamine? Are there brain structural anomalies, such as dysfunction in the prefrontal cortex or the amygdala, that can increase the likelihood of violent behavior? And these biological factors can affect things like impulse control, emotional regulation, and aggression. There are psychological factors. Person that has personality traits or cognitive distortions or mental health disorders that make aggression more likely, like antisocial personality disorder or borderline personality disorder, are two disorders that are linked frequently to aggression and violence. In it, you add to that unresolved trauma or issues with anger management or emotional dysregulation, and you have a lot of factors that can contribute to violent acts. There are social factors. An individual's upbringing, their cultural norms, and environmental stressors. Social learning theory really suggests that individuals who grew up in violent or chaotic environments are also much more likely to learn and imitate violent behavior. So factors like poverty, social isolation, or exposure to violence in the community also plays a significant role. Theories of aggression are a couple of things that we also need to be mindful of. So this is separate from the biopsychosocial model. There are a lot of different theories, and there's three prominent theories that I want to just touch on a little bit about aggression. As I mentioned, social learning theory with Bandura is one of the most well-established theories of aggression. And this theory posits that individuals learn aggressive behavior through observation and imitation of others, especially when those behaviors are rewarded or go unpunished. So, for example, if a child witnesses a parent being aggressive to resolve conflicts and sees that it works, the child will be more likely to adopt similar behaviors. And this theory has strong empirical support, especially in understanding how violent behaviors are transmitted from one generation to the next, or through cultural contexts. There is the general aggression model, which combines elements of, and this is from Anderson and Bushman. So this is in a theory that became prominent in the early 2000s. And according to this theory, aggression results from the interaction of personal and situational factors that influence a person's thoughts, their emotions, and their physiological arousal. So, for example, if an individual has a history of aggressive behavior, the personal factor, and is placed into a highly stressful situation, the situational factor, they may be more likely to engage in violence. So the general aggression model, the GAM model, emphasizes the role of cognitive processes, such as the interpretation of social cues, in determining whether someone will act aggressively in a given situation. And then there's the old school approach to this, the psychodynamic theories approach, the drives approach from Freud in the 1920s. And he proposed that aggression is an instinctual drive linked to what he called the thanatos drive, or the death drive. And the conflict between unconscious desires and societal constraints. And according to Freud, individuals may channel unresolved inner conflicts, frustration, or past traumas into aggressive behavior. Now, while psychodynamic theories are less empirically supported in comparison to social learning theory or aggression models, they remain very influential today. Whichever model you are following along, each model has their values. Each model has their limitations. Forensic psychologists that use the biopsychosocial model gather comprehensive information about the individual. They examine their biological vulnerabilities, their psychological and social environments, and they come up with an assessment. Social learning theorists look at the history of and the historical environment, particularly involving juveniles in the environment that they live in. So there's a lot of different models that can be used for understanding violence. Now, when we look at the risk factors for violence and how they are categorized, we typically will try to organize them in two different ways. First off, into the static and then the dynamic risk factors. And we'll cover why that's important. So one of the key concepts here is this distinction between static and dynamic risk factors. Static risk factors are those risk factors that are typically unchangeable characteristics, or they're past events. You can't change the past, right? That are associated with higher likelihood of violent behavior. And because they're fixed, they serve as a baseline for understanding an individual's predisposition toward violence. So these include things like the history of violence. Does the person have a past history of violence? Have they had repeated or serious incidents of violence? And if they have, that makes them more likely to engage in future violent acts. What was the age of the first offense? Earlier involvement in violent behavior, especially during adolescence or pre-adolescence, is a strong predictor of continued violence in adulthood. What was their criminal history? A lengthy criminal record, particularly involving violent or aggressive offenses, is a significant static risk factor. Did the child have abuse or neglect? And research has shown that individuals who experienced abuse or neglect during childhood are more likely to exhibit violent behavior as an adult. And then finally, are there personality disorders? There's those certain personality disorders, such as antisocial personality disorder, that are often associated with an increased risk of violent behavior. So those are the static factors. And then we have the dynamic factors. And remember, the dynamic risk factors are the changeable aspects of an individual's life or their current circumstances. And these can either increase or decrease the risk of violence. So these factors are particularly important in our ongoing risk assessments, because these are going to fluctuate over time and can be targeted through intervention. So things like substance abuse, If you're having ongoing use of drugs or alcohol, that significantly increases the risk of violence. But treatment and abstinence can reduce this risk. Are there current mental health symptoms? So active symptoms of mental illness, such as paranoia, hallucinations, or emotional instability, can increase the likelihood of violence. Improvement in mental health through therapy or medications can lower this risk. Unemployment or financial stress, so individuals experiencing job loss or financial instability may be more prone to frustration and aggression. But finding employment or improving financial security can mitigate this. And social relationships, a lack of social support or involvement in antisocial peer groups will increase risk. So if you're in a gang or something, or just hanging around with bad people, but having positive pro-social relationships can act as a protective factor. So if you're working in a religious organization, or you're working in a community organization or a charity helping people, that protects. So then we need to look at the protective factors here, because just as there are risk factors that increase likelihood of violence, there are protective factors that reduce the risk. And these factors can buffer an individual against the effects of risk factors and promote positive behavioral change. So strong social supports, like close supportive relationships with family and friends or community members, makes a person less likely to engage in violent behavior. Stable employment, having consistent employment, offers financial security and a sense of purpose, which can significantly reduce stress and prevent violent outbursts. Participating in therapy or counseling or substance abuse treatment can reduce the likelihood of future violence. Positive coping mechanisms, like being able to manage your stress or your anger or your frustration without resorting to violence. If a person learns these through, say, something like cognitive behavioral therapy, they are less likely to engage in violent behavior. And if there's a structured environment, if there's a stable, structured environment, such as living in a halfway house or attending regular probation meetings, all of this provides external accountability and reduces the opportunities for impulsive or violent behavior. So when it comes to violence risk assessment, it really does account for both risk factors and protective factors in order to create a balanced and accurate picture of an individual's potential and future risk of violence. So we do this by doing things like that structured professional judgment. And all of this is going to guide in creating a good sense of what is going on with a person and how likely they are to engage in these. So I want to take a little bit more time and again go through some of the risk assessment tools. We've already talked a little bit about the actuarial tools and the structured professional judgment approaches. When we think in terms of the actuarial tools for violence and risk assessment, one of the key ones we've already mentioned is the Violence Risk Appraisal Guide. And this really kind of weighs a number of factors like criminal history, the age of the person, psychiatric diagnosis, and 9 other types of things that go into that. There's also something known as the Static 99, which is another fairly prominent actuarial tool, and it's designed really for the risk of sexual violence, but can often be used in more broader contexts in violent recidivism. And it looks at some of those static risk factors, such as criminal history and age of first offense. Now, while this tool offers highly predictive accuracy, it doesn't account for a lot of the dynamic factors that can change over time, which limits its flexibility in some clinical settings. But it still has that value of having a fairly strong, highly predictive accuracy. And it's easy to administer, so it's very valuable that way. There is also what we had talked about, the structured professional judgments, so things like the HCR20. And we've talked a little bit about that, about how it deals with the historical factors, the clinical factors, and the risk management factors. But there's other tools out there, like the START. The START is the short-term assessment of risk and treatability, which is another structural professional judgment framework that's designed to assess both the violence risk and potential for positive outcomes in short-term scenarios. So it evaluates dynamic factors and allows for treatment planning alongside the risk prediction. So this one is especially good in inpatient settings, in psychiatric settings, because it considers both those static factors but also the dynamic factors. You get a little bit more of a nuanced picture there of what is going on between the things. So there are different types of risk tools, and it's important to understand what each one does so that you can choose the type of tool that best fits the context and your needs. So we've already looked a little bit at some of the questionnaires there, and so I just want you to think about, what was your risk at the beginning of this lecture? Was it low? Was it moderate? Was it high? What can you do to possibly change that into the future? What were your static factors? What might be your dynamic factors? And how can you improve your life? And I think it's important for every person to consider this, because none of us wants to cause harm to others. And recognizing our own vulnerabilities can go a long ways to changing that. Now, let's get into recidivism and risk assessment, because remember, recidivism, generally speaking, is the tendency recidivism is generally defined as the tendency of previously convicted individuals to engage in criminal behavior again after their release from custody or after completing their sentence. And it's really important to note that recidivism can involve a couple of things. It can involve general recidivism, which is, being involved in any criminal behavior, or violent recidivism, which is specifically involving violent acts. So general recidivism would be things like, just anything that can go on, like property crime or drug-related offenses, or, minor legal infractions. And violent recidivism has to do with reoffending with crimes of violence, such as assault or murder or domestic violence. And there are some key instruments for predicting recidivism risk, and they typically are under that flexible structure of the professional judgment, the structured professional judgment frameworks that we've talked about. And here's one that we haven't talked about before, something called the level of service inventory. The revised version is what we're in now, which is one of the most widely used actuarial tools for assessing the risk of general recidivism. And what it does is it looks at criminal history, which is a static factor. It looks at substance abuse issues, which is a dynamic factor. It looks at family and marital relationships, again, a dynamic factor. It looks at employment status, which is a dynamic factor. And so this level of service inventory is particularly useful in correctional settings, because it not only predicts recidivism, but also helps inform case management and treatment planning by identifying specific areas of need. We've talked about the static 99, which looks at static factors. We've talked about the HCR20, which looks at the historical, clinical, and risk factors. All of this needs to also be tied in with considering special cases, because there isn't one size fits all tool for assessing recidivism. There are tools for juvenile offenders, tools like the youth level of service or the case management inventory, which is known as the YLS, the CMI. And it looks at different dynamic factors that go into the decision-making process. There's sex offenders. Sex offenders, the static 99 is a good one for that. For violent offenders, where we want to look at both static and dynamic factors, again, the HCR20 would be a good one for that. Now, let's look a little bit at the neurobiological and the neuropsychological and the biological correlates of violence, because understanding the role of the brain function and neurotransmitters and biological factors can really help in this process. So we need to kind of first off remember that neurotransmitters are chemicals in the brain that transmit signals between nerves. So they play a fairly crucial role in regulating things like mood or behavior or impulse control. And so when there's a disruption or imbalance in certain neurotransmitters, this has been closely linked to increased aggression and violent behavior. So when we think in terms of neurotransmitters, we think in terms of things like one of the big ones, serotonin. Serotonin calms things down. It's used as an antidepressant, but it's really about turning down the nervousness, the worriness, thinking that the world is a dangerous place. So if you feel safe, you're not likely going to be violent. But if you have low levels of the serotonin, then you're going to feel unsafe. That's also associated with impulsivity and aggression, which can lead to violent behavior. Dopamine, it tells us we like something. And dopamine dysfunction means that life can be a very confused place, and gets very confusing when you have things like addiction, and that can play into violent behavior. Also, high dopamine activity is associated with being more prone to seeking out aggressive behavior, because it's about gaining power and respect and resources. So it depends on where you are and what the level is. There's also norepinephrine, which is a bit of the fight and flight response, and it's tied to arousal and stress reaction. So elevated levels of norepinephrine can lead to heightened emotional responses, increased aggression, and a tendency toward impulsive violence, particularly in stressful situations. So dysregulation, I hope you see here, plays a huge role in this. Brain structure also plays a role, because having a good, healthy prefrontal cortex means that you're making good, slow decisions. You're controlling your impulses. You're making moral judgments. You're planning. If there's damage to your prefrontal cortex, then you are having less ability to think about others. You're having less ability to control your emotions. You're having less ability to think slowly and to make decisions rationally. So, it leads to higher levels of aggression and violence. The amygdala, that small little structure that deals with emotions. It's central to emotional processing, particularly fear and aggression. An overactive amygdala is linked to heightened emotional responses, violence, aggression. The hypothalamus, too, plays a role here in the fight and flight response. And while it studied less than the damage to the prefrontal cortex or the amygdala, dysfunction in the hypothalamus has been linked to impulsive aggression, at least in a few studies. So, traumatic brain injury plays into this as well. So it's important when you're doing something like a forensic neuropsychological assessment to evaluate how brain function and neurobiological factors can contribute to violent behavior. So it involves doing a comprehensive test of cognitive abilities, of impulse control, of decision making and emotional regulation. It evaluates brain function like the prefrontal cortex and the amygdala, how likely an individual is to engage in violent behavior based upon neuropsychological deficits. And so this all, and traumatic brain injury, a neuropsychological assessment can reveal significant impairments in the prefrontal cortex, which leads to poor impulse control and difficulty regulating aggressive responses. And based on these findings, treatment recommendations might be, cognitive behavioral interventions that provide improved decision making and impulse regulation, along with some close monitoring to prevent further violence. So when we understand the neurobiological correlates of violence, that can have a significant implication for risk violent assessment and risk management. And when we incorporate all of this into our legislation, into our management of people, and into the care of society, it goes a long ways to helping to reduce violence in the community. Now, let's take a look at parole hearings. Parole decisions are really a crucial moment in the criminal justice process. This is where the release of an offender back into the community is considered. And these decisions hinge on a careful evaluation of the individual's risk to public safety, their likelihood of reoffending, and their readiness for reintegration to society. So it isn't about, I like this person or I don't like this person. That has nothing to do with it. Parole hearings are designed to assess whether an incarcerated individual can safely return to the community before the end of their sentence. So during these hearings, professionals use various assessment tools to evaluate several factors. What is the risk of recidivism? If we let this person out, are they likely to reoffend? Both general recidivism and violent recidivism. What's their risk of violence? Are they a threat to the public? Are they a threat to specific people? How has their rehabilitation progress been going? Are they using drugs? Have they completed anger management? Are they in need of mental health treatment? So evaluating all of this goes a long ways into this. So there's risk assessment tools like the level of service inventory, like the HCR 20, like understanding and getting records from mental health or rehabilitation progress, about substance abuse treatment programs, about behavioral change programs, about risk management programs. Are they able to notch into stable housing? Are they able to secure stable employment? Are they able to have good positive social supports like family or social networks? Are they able to be under supervision and be in compliance with that supervision, like checking in regularly with parole officers, engage in substance testing, mandatory participation in therapy or support groups? All of that goes a long ways to making that decision in this process. So I want to also just take a moment and focus on treatment and intervention strategies. that are formed by the violence and recidivism risk assessments. Because once an individual's risk level has been determined, forensic psychologists and treatment providers and correctional professionals need to develop strategies to reduce the risk of future violence or reoffending. And these strategies are tailored to address the dynamic risk factors identified during assessment. And the whole goal here is promoting rehabilitation and reducing the likelihood of recidivism. So when we target the dynamic risk factors, which by their definition change over time and then are responsive to interventions, we have our primary focus of treatment plans. So things like substance abuse treatment, like cognitive behavioral therapy, that can target criminal thinking patterns, can focus on relapse prevention. We can have medication-assisted treatments. So someone that is suffering from opiate or alcohol addiction might go on methadone or buprenorphine or naltrexone. Someone in anger management or emotional regulation might be going through programs. And all of this can play a role in, when we understand the risk factors. What I'm saying is we can better target the dynamic risk factors and thereby reduce the risk to society of these people entering back into the community. So when we tailor the interventions to the individual's risk profile, we then have a better way of moving forward. So we can focus on things like substance abuse, lack of problem-solving skills, or poor emotional regulation, and help the person. So in so doing, have better outcomes overall. So this brings us to the close of this lecture, and I'd just like to highlight 3 key terms that I'd like you to kind of keep in mind as you move past this lecture. First one is, what is a dynamic risk factor in terms of violence assessment? And that is those variables that change over time and are responsive to intervention. So these factors may increase or decrease the risk of future violence or recidivism, depending upon how they're managed. So some examples of dynamic risk factors would be things like substance use, mental health symptoms, and employment status. Cognitive behavioral therapy. Cognitive behavioral therapy is an evidence-based therapeutic approach that focuses on changing maladaptive thought patterns, so criminal thinking patterns, and the behaviors that derive from these. And because it's so focused, it's used to address a wide range of issues, such as aggression, substance abuse, emotional dysregulation, all of which are linked to violence and recidivism. So it's a clear treatment tool for dealing with this kind of issue. And then there's the structured professional judgment, which is a general approach to risk assessment that combines both empirical actuarial evidence and clinical expertise. So an example of a tool that uses the structured professional judgment would be something like the HCR20. Now, the question: what are some dynamic risk factors of violence? Well, some clear ones would be things like substance use or mental health. And hope you understood and appreciated this lecture and enjoyed this lecture. And as we close out, I'd just like to remind you that assessments are done in order to help us to understand the perpetrator, but also to protect society. And so they're a very valuable tool that we need to continue to revise, hone, do research on, to use, and to understand when best to use them within different contexts. Hope you enjoyed this lecture. You take care. Bye-bye.